Hello, and welcome to the State of 911 webinar series hosted by the National 911 Program. My name is Sherry, and I will be the moderator for today's session. On the next slide, this webinar series is designed to provide useful information for the 911 stakeholder community about federal and state participation in the planning, design, and implementation of Next Generation 911 or NG911 systems. It includes real experiences from leaders utilizing these processes throughout the country. Today's session is going to provide information on the implementation of 988 for mental health emergencies, as well as an overview of NG911 training that was created by the Washington, D.C. Office of Unified Communications. For closed captioning, please copy and paste the URL link in the chat window to an additional web browser. For more information on National 911 Program webinars, or to access archived recordings, or just to learn more about the National 911 Program, please visit 911.gov. Feedback or questions about the webinars can be sent to the National 911 team at missioncriticalpartners.com. And if we go to the next slide, today we have some information that the National 911 Program would like to make you aware of. The 911.gov Documents and Tools website has been updated with new resources and improved access. 911 stakeholders are encouraged to submit links and documents that would be of use and interest to 911 colleagues, such as policy documents, plans, and reports covering topic areas like governance, management, technical, operations, and standards and best practices. You may access the web page under the 911 System Resources drop-down menu or scan the QR code in the bottom right corner of this slide. Content can be submitted by clicking the online submission form on the left side of the Docs and Tools page. Next slide. The National 911 Program would also like to invite you to visit the 911 telecommunicator Tree of Life. Share the name of a remarkable 911 telecommunicator who has inspired you. Share your story at 911treeoflife.org to honor a special 911 telecommunicator who is making a difference in your community. And finally, some housekeeping notes on the next slide. Please note that all participants' phone lines have been put in a listen-only mode, and this webinar is being recorded. To ask questions of our presenters, feel free to take one of two actions. Using GoToWebinar's question feature located on the right-hand side of your screen, enter your question at any time during the presentation, and it will be entered into the queue. This feature is not visible while your screen is in the expanded page view. Or if you'd like to ask your question live, use the raise hand feature to request your phone line to be unmuted, and you will be called upon to ask your question. Individuals registered for this webinar will receive access to today's PowerPoint presentation along with the webinar recording. And with that, I would like to turn it over to Lori to introduce our first speakers, Richard McKeon and John Draper. Lori?
Thanks, Sherry. Joining us today to give us an update on the implementation of 988 are two folks that we've been working with a little while on this issue. The first is Dr. Richard McKeon, who is the Chief of the Suicide Prevention Branch at the Substance Abuse and Mental Health Services Administration at the Department of Health and Human Services. Also joining us is Mr. John Draper, who is the Executive Director of the National Suicide Prevention Lifeline and Executive Vice President of National Networks for Vibrant Emotional Health. Thank you both for joining us today. Please proceed.
Thank you so much. It's a pleasure to be speaking with you all today because the interaction between 988 and 911 is going to be critical, I think, for both of these vital services. So we're looking forward to the opportunity to updating you, to hearing your questions, and most importantly, to work with you through July 2022, which is the date for that every cell phone, every landlines, and every voice over internet provider needs to have made 988 operational. We look forward to working with you closely through that date, but also for years beyond that. So we can move to the next slide. Standard disclaimer: if I say something you don't like, please blame me, don't blame SAMHSA. Next slide. So it's important to be aware that this is one of a number of noteworthy developments in behavioral health crisis services in the United States. Obviously, what we'll be talking about mostly is the implementation of 988 as the nation's new National Suicide Prevention and Mental Health Crisis Line by July 16th, 2022. The existing number, 1-800-273-TALK or 1-800-273-8255, will not be going anywhere. It will still exist. It will continue to be operational for anyone to use it, but we will begin to promote 988 once it is universally available. It's also important to be aware that 988 will be routed in all instances to the National Suicide Prevention Lifeline. So a very different structure than exists for 911. So all of the cell phone companies, landlines, et cetera, under order from the FCC, are setting up 988 so that it is directed to the infrastructure of the National Suicide Prevention Lifeline. In essence, the number will actually point to the 800-273-8255 number and then be distributed to the entire Lifeline network based on the area code of the person's phone. It also will give them the opportunity to press 1 to be connected to the Veterans Crisis Line, or to press 2 to be connected to the Spanish language sub-network. In addition to these activities, 988, last year the Congress instituted for the first time a 5% mental health block grant set aside for crisis services, and this 5% set aside also applied to an additional $1.5 billion in block grant funding. SAMHSA's mental health block grant is a program. It's a formula grant. Funding goes to every state and a number of the Pacific territories through this. And so this 5% set aside applies to all of them. SAMHSA has published national guidelines for behavioral health crisis care, which is available on SAMHSA's website, and I'll talk a little bit more about. And then currently the FCC has issued a notice of proposed rulemaking on texting to 988. So the FCC is looking at, but has not yet made a final order, on asking the telecom companies to facilitate texting to 988. Next slide, please. So I mentioned SAMHSA's national guidelines for behavioral health crisis services. That's included in this document, crisis services, meeting needs, saving lives. And it includes the idea that what we want to see is that there are 3 core pillars of behavioral health crisis services in the United States that we think every community needs to have. One is access to a crisis hotline that can meet the person's needs over the phone, but can also coordinate what they need if talking on the phone is not going to be sufficient for them. The availability of a mobile crisis team to go to where the person is, because sometimes someone will need to come to them, as well as crisis receiving and stabilization units that can be an alternative to inpatient hospitalization. Next slide, please. So this slide gives you a sense from the standpoint of a person in crisis, how we think the system should work and what SAMHSA is working towards. So the availability of 988 as a number that everyone can remember to call if in crisis, if thinking about suicide. And our estimates, and this is data that actually comes from Arizona, that about 80% of the calls should be able to be resolved on the phone. And that if it's not, that a mobile crisis team can respond to the person. They are oftentimes without the police. And then for those for whom the mobile crisis visit is not enough, the availability of behavioral health crisis receiving and stabilization units. And we hope that this will help, the current situation where too often people need to be transported to emergency rooms as the only option, where they may end up staying even days, waiting for a bed when it's quite possible they could have had their needs met otherwise. Next slide. These same core elements have been emphasized in the Surgeon General's recently released call to action on suicide prevention. They had these crisis care recommendations. And you can see it's the use of the crisis call centers as statewide or regional crisis center hubs. So that can coordinate, that can dispatch mobile crisis teams, or at least coordinate closely with mobile crisis teams, that can not lose track of people so that people don't fall through the cracks of fragmented service delivery systems, and ensure safe care transitions for patients at risk, and to ensure that the crisis infrastructure is sufficient to support implementation of 988. Next slide. So the National Suicide Hotline Designation Act, which was passed in October 2020, did a number of different things. It established 988 in statute. The FCC has done a report on geolocation. Right now, the situation is that while 911 does have geolocation built into its system, the Lifeline currently in 988, at least as of now, does not. SAMHSA and the VA responsible for a joint report to Congress on resources. SAMHSA did a report on training and access for high-risk populations. It also authorized states and localities to institute fees similar to 911 funding, but these need to be quite separate from each other so that there is no potential reality or appearance of a diversion of funds. 15 states have introduced legislation, became law in Utah, Virginia, actually also Colorado and Nevada. Now a couple of states have also implemented commissions to look at 988 moving forward. Next slide. And here are some of the key issues. One is that to assure that there's adequate community crisis center capacity to answer what we anticipate to be a significantly increased number of calls to the National Suicide Prevention Lifeline. That to make sure that there is coordinated crisis response with follow-up afterwards, so that people have someone in contact with them who is able to help them make sure they get the help that they need and that they do not enter a period of intensified risk where a suicide or a suicide attempt might happen. I mentioned about texting. We need to promote awareness of 988 and when it should be called. And then particularly important for this audience, the need for collaboration between 988 and 911 on the federal, state, and local levels. We do think that 988 has the potential to reduce unnecessary police EMS utilization and emergency room boarding, but that's going to take a lot of work, development of protocols about when, for example, police and EMS are needed, when they're not, moving forward. Next slide. Just so that you know that there is a strong and robust evaluation literature on the effectiveness of the National Suicide Prevention Lifeline. We've shown that calls to the Lifeline, callers intend to die, can be significantly reduced during the call, that even when there are situations of imminent risk, The counselors are able to obtain collaboration on over 75% of them. That follow-up calls are experienced by 90% of callers as helping to keep them safe and not kill themselves. And for our chat service as well, suicidality being reduced among 50% of those accessing the chat system. And that third-party callers who call the lifeline when they're worried about someone who's at imminent risk are able to provide a range of interventions which can supplement and at times replace calling 911. Next slide. I mentioned the core pillars of the national guidelines. That's based on what was called the Crisis Now model, the idea of a call center hub, mobile crisis, and crisis facilities. And this notion of air traffic control is that if you fly from DC to Los Angeles, there's never a time when there's not an air traffic controller who knows where that plane is and is staying in contact with it. But we think that for behavioral health crisis services, there needs to be always someone who knows what the status is and stays in contact and makes sure that someone does not fall through the cracks. Next slide. And we think that a crisis call center hub, ultimately having caller ID, GPS for mobile team dispatch, bed registries, outpatient scheduling. These exist in some places, but such as in the Georgia Crisis and Access Line, but not everywhere. So that's the goal, is to increase these functionalities. Next slide. And this slide basically is to underscore the point that at a time when we can track a package halfway around the world, it should be unacceptable in the United States of America for us to lose track of people in suicidal crisis between gaps in our behavioral health crisis systems. And that's one of the things that we are hoping that 988 will be able to make a substantial contribution to resolving. Next slide. And that's my contact information. And I'm now pleased to turn it over to Dr. John Draper, who is the project director for the National Suicide Prevention Lifeline.
Thank you, Richard. Appreciate it. It's great to be here with you all alongside Richard. We've been working together with since 2004. We're at a different time in a different place, doing something a little different. And that's what this 988 and 911 collaboration is going to be over this year and in the coming years. If we go to the next slide, this is another disclaimer. Again, blame me. Don't even blame Richard. And don't even blame Samsung. Anything I say is I'll be responsible for all of the things I'm talking about today, which starts with the next slide. Richard did a really nice job, I think, of summarizing what, or at least implying some serious differences between 988 and 911. But I do want to just underscore it so we're very clear. Richard mentioned that one thing that's clearly different relates to centralized network routing. All of you are extremely aware of how things are routed in 911. In this case, we're talking about from the caller going to a centralized administrator who then dispatches to the, hopefully the nearest location of the crisis center to the caller. That doesn't often happen necessarily because the person could be calling on a cell phone, and we route by area code until we have geolocation. We're not going to have that capability to be absolutely certain that we're routing to the nearest center, but that is what we're trying to do. In the event that that center is unable to answer a call for some reason, it could be a power outage, it could be a surge in calls, we can efficiently utilize backup centers to make sure that every call is answered. The other thing about having a centralized administrator, which in this case is Viper Emotional Health, allows us also to have standardized quality assurance expectations across the network. So the hope is that answering a call in Mississippi will be the same as answering a call in Minnesota and so on. As Richard also indicated, that one thing that is different, even though 911 certainly provides a critical life-saving service and can intervene on the phone, it's not typically seen in and of itself as a crisis care service where it doesn't have to or end up in a dispatch most of the time. That is, as Richard noted, quite frequent when people call the Lifeline that most of the time we can resolve the crises according to the research and data. So the person doesn't necessarily need additional care, certainly not urgent care. However, in the event that they do need it, we have the capability in many places to provide connections to mobile crisis teams, outreach teams, and just about everywhere, really, 911. But what Richard was describing in terms of that crisis care system is a bit ideal. What we saw in Arizona and what we see in Georgia, what we see in metropolitan areas is not true necessarily of most rural and absolutely not frontier areas. So that ideal crisis care system that extends beyond this front door of answering contacts for phone call, text, or chat, in many places, you're not going to have for a while additional outreach capabilities and dispatch capabilities. Next slide, please. So what we do have and what we can expect on July of 2022, when all platforms are capable of connecting 988 callers to Lifeline, is a system that looks pretty similar to what we have now. Right now, we have about 190 centers. We answered last year about 2.4 million contacts, not just calls, but checks and chat too. We have backup centers as noted. We have chat centers as noted. And if you press 1, you can get the Veterans Crisis Line. Press 2 for Spanish-speaking callers. And we also have the ability to provide other languages through teleinterpretation services. But again, to make sure every call is answered, there are backup centers in the event that local centers cannot get to it. Next slide, please. So how often are we engaging with 911 now? About 23% of the time, our callers to the National Suicide Prevention Lifeline are experiencing suicidal distress. But only about 2% of the time, they're going to require 911 dispatch. Again, speaking to the data that Richard was talking about, resolving a lot of the crises. However, it's a little different with online services, crisis chat. 47% of the chat visitors are in suicidal distress. So there's a higher rate, about twice the number of people who are in suicidal distress in crisis chat, and less than 1% require 911 dispatch. A lot of reasons for that. Happy to go into that later if you'd like. But we have a number of challenges as I talk to you about the process of how we link to 911 through phone and chat. So for example, with phone, we'll use, typically through consent, we can find out exactly where the person is, and that's really what we seek and get the overwhelming majority of the time. People call us because they want help, and we'll give it to them. They'll tell us where we are, and if they need care, we can send it to them. But in some cases, they may be unwilling or unable to tell us where they are, and that makes things tough, especially if they're on a cell phone and we don't know where they're located. In the event that we have some sense of where they are, we can look up the local PSAP. We have a PSAP lookup tool that was created for us by Entrado, and that can help us find the right PSAP. Otherwise, it's a little bit of a challenge calling up 911 and saying, we're not sure where this person is. Here's their phone number. Can you help us? That's kind of where we're at. For chat, we look up the location of the chatter's IP address, and then we go back to that PSAP lookup tool, and then we provide info to that PSAP, which you note here, and hopefully they can locate them from there. Obviously, there's a number of challenges with this current system. The location-based routing I noted is very limited by area code. IP addresses are unreliable as people are on the move. And there's also the unknown outcomes of 911 dispatch and transport. Richard said it's hard to imagine that we can track packages, but we can't track where people who are suicidal are once we dispatch help for them. And that is more often than not very true. There are some places where 911 can tell us if the person was picked up, if the person was transported, and where they were transported to. In most cases, they are not able to do that yet, and that is something that we're hoping we'll be able to do more efficiently with 988. Next slide, please. We've been working with Nina for several years now. Nina's been really helpful in terms of helping us get a sense of how we can better collaborate with PSAPs. This The suicide prevention standard, which was initially published in 2013, we're updating that currently, is really focused on local centers collaborating with local PSAPs. In this case, mostly Lifeline centers. And a lot of that is about communications. A lot of that is about training. A lot of that is about trading information that is necessary to keep track of the individual who we just contacted 911 for, as I was just describing. But to give you a sense of how often our centers are formally connected in some way with their local PSAPs, only about 21% of them are. Most of them say they have informal relationships, but in terms of standardized agreements or understanding of how to exchange information in a more formal way, very few of our centers are currently able to do that. Next slide. We do expect things to be very different over time. Even though we have about 2.4 million contacts last year, we'll probably get, maybe close to 3 million this year. Things will change when it starts being marketed. 988 is not likely to be marketed until probably at least 2023. But when it is heavily marketed, we do expect that there will be quite a huge change in volume. That includes diverted volume, not only baseline volume, which goes up for the Lifeline every year, but also diverted volume from people who might otherwise be calling local crisis helplines who hear about 988 instead, as well as people who might otherwise be calling 911 who say, no, the right number for me is 988. A lot of that depends on how we market it. And again, so does the new volume estimates. So getting people who might not have called any helpline before is dependent entirely on how effectively we can market and reach people who didn't know how they can get help from this 3-digit number. So we could get, we estimate in kind of this moderate level model, we could get in a 1 year of marketing about 3 times what we're getting now. After 5 years, we do expect market penetration to make a difference. We could be up to 24 million contacts a year. Next slide, please. So we've got a lot of work ahead of us to be collaborating with 911, both on the marketing and some of the protocols. And some very, very key collaborators for us will be NENA and NASDA. We've been talking with them about establishing a partnership, and that agreement would allow us to enable protocols, models for 911 and 988 interoperability, also to engage with all the members of these organizations so we can promote local collaborations and disseminate protocols that have been determined to be most effective for 911 and 988 centers to be working together. I also want to work with them on public messaging for when to call 988 as opposed to 911. How do we apply geolocation technologies for 988 callers unless and until FCC can grant us the kinds of 911-like permissions that we seek? We also want to see how we can co-facilitate community of practice sessions for 911 and 988 services. That's something that we can do and we plan to do with NENA, NASNA, the U.S. Department of Transportation's Office of EMS, whom you know very well, SAMHSA, the VA, FCC, our team at Vibrant, law enforcement, crisis center entities. This community of practice will again help us establish more protocols and promising models for collaborations between 911 and 988 centers that we can hopefully replicate elsewhere. Next slide. That's it. That's my contact information, and we're happy to answer any questions you may have.
Thank you. Thank you to both Richard and John. And so now we're going to start the Q&A portion of our session. And as a reminder, you can ask a question by using the question or by raising your hand. Sheila, do you want to read us the first question?
Yes, thank you, Sherry. The question is asking, does 988 line have applications for people with more generalized mental health issues, specifically targeting those who may be possible active shooters?
Great question. About 77% of our callers are not reporting suicidal crises and are in emotional distress. It's a great question about dangerousness to others. Interestingly, we have had an incident in the past that I'm aware of where a center was able to prevent a mass shooting from occurring at a school several years ago in Colorado. And we recently were contacted by a researcher who's working with the federal government to determine how we can best prevent active shootings and one of the things, or mass shootings. And one of the things that he was noting is data that we're aware of, that people who are mass shooters often are suicidal first. The degree to which they contact our line is unknown. But Richard, I think we both know that it will be important for us to find ways to assess for violence to others, as well as assess for violence to ourselves.
Yeah, I would certainly agree with what John has said. The law establishes 988 as the nation's national suicide prevention and mental health crisis line, and we have never insisted that someone be suicidal in order to be able to call. We would rather that they be able to reach out to us before they get to such a desperate state where they're thinking about suicide. And we know that suicide risk is heightened among a broad array of mental health and substance use diagnoses. And certainly agree that it's important for Lifeline centers for staff to know how to assess for violence risk. And there are a lot of similarities between a suicide risk assessment and a violence risk assessment, but also a couple of key differences. So that's a very important point and something we're certainly very aware of.
Thank you. We have a caller on today from Alaska, and they're sharing that in Alaska, majority of their communities don't have 911. They have the highest suicide rate, so they're asking, is there any study that is ongoing for their situation in Alaska?
Yes, it is certainly the case, and we're very aware of the extremely high rate in the state of Alaska, particularly among Alaska Native populations and Alaska Native youth, and that there are remote areas in Alaska where a number of the things that we've talked about are certainly much more challenging, such as the ability to send a mobile crisis team. In most places, that's a case of people getting into a car and driving to the location, there. But there are Alaska Native villages that can only be accessed by plane and that don't have roads. So there are certainly unique challenges around Alaska, and obviously phone access is part of that, whether it's cell phone access or landlines. And so those issues that 988 could certainly mirror some that exist for 911, as well. SAMHSA does have numerous grants that go to the state of Alaska, but I think that, what saying underscores the importance of paying attention to the unique needs of Alaska communities.
Thank you. The next individual is stating, I like the idea of specific options for veterans, for example, press 1, and Spanish language, press 2. The question is, have you considered an option for police officers, firefighters, EMTs, and paramedics as a press 3 type of option?
It's another really good question. There's quite a number of what we might refer to as high-risk populations that have been proposed as additional options and to provide specialized services for, like the Veterans Crisis Line. We've heard that for LGBTQ youth. We've heard that for Alaskan Natives and American Indians. We've heard it for occupational groups like first responders. We've also heard it for doctors and healthcare workers. One of the things that's a real challenge for us is creating an automated greeting system that gives you a lot of options, so everyone has to listen to those options. And when you're in crisis, it could be a challenge for a number of people to listen to all of those options. But we want to find some way to provide those specialized services. So we're working with SAMHSA to really determine, are there technical means for us being able to do this efficiently? Should we also have certain centers in our network that, or workers that are better trained to deal with these populations? So all of these are challenges that we will be undertaking and studying and implementing over time over the coming years.
And I would just add to that Congress has asked through the Hotline Designation Act required SAMHSA to do a report on access and training for high-risk populations. And as part of that, to specifically address the question that was just raised, which is the use of the IVR, the integrated voice response, basically the recorded message, for further high-risk populations to utilize. That report is currently within clearance, but we anticipate it will be transmitted to Congress, shortly, and that we would hope it will be then publicly available after that. So that we'll be able to get everyone a kind of a detailed read on SAMHSA's thinking regarding that issue.
All right. Well, thank you to both of our speakers. I know we had a lot of interest in this topic, and I know we have several questions that we didn't have time to get to. We will collect the questions. We will provide them to our speakers. And when the recording and the slide deck are posted to 911.gov, we will also provide the questions with responses along with those files. So I'd now like to ask Lori to introduce our next speakers, Selena Macarthur and Heather Mcgafin.
Thanks, Sherry. When these two ladies originally provided us with this information, it was as a presentation to the grantees for the 911 grant program. And we found the information so interesting that we asked them to do a redo. We asked them to present it again to the larger group. So with us today is Selena Macarthur, who is the CAD and Telephony Program Manager at DC's Office of Unified Communications. And with her is Heather Mcgafin, who is the Director of Emergency Operations for OUC. Ladies, the floor is yours.
Hi, good afternoon or good morning, depending on where you are. This is Heather Mcgafin, and I am the Director of Emergency Operations here at the Office of Unified Communications, and we are the 911 Center for the District of Columbia. Selena is doing I3 testing right now and got held up. So I'm going to fly solo on this, but we do have her contact information, and she is more than willing to share her knowledge. So you can go ahead to the next slide. And this is just our contact information, and we'll be sure that Sherry and her team get that out. So our next gen 911 implementation here at the OUC. When that started, we were doing the 911 alley migration. We went into phase 2 with the LAN and WAN migration. Phase 3, we transitioned our Viper, and Selena would be doing a way better job of getting into the nitty-gritty of all of the technology of this. And then we began doing our regional interoperability. So in the Washington, D.C. area, if you're familiar with the geography at all, we are surrounded by Montgomery and Prince George's County in Maryland, and Fairfax, Arlington, and Alexandria in Virginia. And our region, our national capital region, works on a lot of projects together. We're in the Council of Governments together. We do a lot of transferring throughout the day of resources. And, just as we commemorated the anniversary of September 11th, and And we really got a chance to look back on that day and how interoperability for us was a struggle. And as we moved forward as a region and as leaders in all assets of public safety, 911, police, and fire, you know, we really saw the need of being one and moving towards next generation as one. But most of our next generation 911 implementation here was done independently of those regions. The leadership here decided at that time that they were going to move forward, as did the counties around us, and so things were kind of happening in parallel but not together. Now we're all on the same train and we're able to connect those calls, because one of the big things about us is in a city, and if you have large cities or high populous areas in your jurisdictions, you know, especially if you're a border state, that sometimes calls don't come right to you. So with the implementation of Next Generation 911, that gets fixed. And, you know, as we move forward, we were like, wait a second, we're making all of these technological changes, but how are we going to train our call takers and our IT staff to understand what we're doing? How do we better, you know, how do we kind of add to the recipe to make Next Generation 911 digestible to the people it matters to the most, those folks that are working in operations? So we started to devise that plan, and we said, okay, we've got to make them understand this, but we have to make sure that they understand why we're making this change, right? Because everybody always struggles with change, especially when it's such a large change. But what we found here is in our implementation, we were doing it in small pieces. Okay, we'll upgrade the technology. They're going to see some over-the-top applications that'll help them better work with the mapping system. They are going to, you know, start seeing less calls that they're having to transfer out. At some points, we were transferring anywhere between 30 and 50,000 calls a year to neighboring jurisdictions, and they were doing the same. You can switch to the next slide. So we got together and we said, okay, let's train the people that it matters to the most. Let's identify who those people are. Here, if you've ever been to the OUC, it's a pretty massive floor, and on that floor we have our 911 call takers, we have our police dispatchers, and then we also have fire dispatchers, and we also have a side that's running our 24/7 operation of 311. And so while we're not training 311 on the Next Generation 911, we do get some questions, and we are able to provide them with some information about how you know, it affects them. Sometimes people call 311 and say, you know, I called 911 the other day and I got Fairfax County, but I was really in DC. How did that happen? But we focused on our three largest groups in 911 operations: our operational staff, our IT staff, and then our training staff. We have an IT staff of about 50 people, and at any given time, we have 3 to 4 IT specialists on our operations floor. That is a 24/7 operation, and you know, if you're in a larger center, I would highly recommend having that, especially as we migrate to new technology. Things happen. Our supervisors are busy. We're taking 5,000 plus calls a day and dispatching close to 20,000 incidents between fire and police. So we don't always have time to you know, really be able to recreate what happened. A lot of times when we're experiencing an issue with our technology, we're picking that person up, we're moving them, and we're letting IT come in and take over that position to try to recreate what has just happened. Even if you don't have IT staff on the floor, I highly recommend that you train your IT staff to identify those issues, because, you know, as we migrate to this new technology, the way things were for service level agreements and vendors looks a lot different now than it did then. And then we have about 20 people in our training staff. Those folks are creating and coordinating and delivering training. They're also our CTOs or our and our quality assurance team members. So when we're doing quality assurance, we're looking at not just how the call was processed, but we're making sure that people are using the technology in an appropriate manner. When you have a veteran workforce like we do here in Washington, D.C., you realize sometimes that old habits die hard. And so the days of, erasing the alley spill and putting in the address as the person is telling it to you, or not paying attention to that, those are all things that we're trying to pick up on as we're training people. You don't have to do that. You can rely on the technology now. When you're getting that coming in, it's right. It's a dispatchable location. So we focused on those three training groups. Next slide. And then we went through and we looked at what did we need to train the individual groups on, because what we're training our IT staff on and what we're training our operations and training staff on were a little bit different. So we developed a training plan, and these are the courses or the modules that we designed for each of the three categories. And we aligned all of those with the recommended minimum training guidelines for the telecommunicator, which if you are not familiar, I would highly suggest you get familiar. It really is a saving grace when you're trying to develop curriculum and push it forward, and not just the curriculum for your call takers or dispatchers who are starting out, but it was really helpful for us as we were developing this curriculum to make sure that we didn't overlook anything. Okay. You can advance, I'm sorry. And then this was just our syllabus. We had, as you can see, all of these courses, we identified who should be taking what, and then the dates that we had proposed, and then whether or not we got there or not. So this is accurate from when from last week. We've already done some of the modules. September 2021, that next generation module, we're in that now. We actually had to kind of shift some things. We've had some major events happen here in Washington, D.C. this year. And so obviously those have been shifted, because of that. But for the most part, we're staying on schedule here. One of the other things that I will say is, as we were designing these modules, we were really fortunate, and I hope that each of you would have that same good fortune in reaching out to our vendors. They offered us a lot of material. They shared what they could. We did rely on them for some of the training as we put in a new telephony system. All of our call takers took that training. And as we talked about, building out this training syllabus that would withstand the test of time, we were able to get some of the diagrams and the information that was taught in that initial class. So that would be another suggestion, is to reach out to your resources, reach out to your vendors, see what they can help you with. Because as as we're continuously hiring people, we want to give them the same training experience that we had given our call takers who are already here. When the training or the technology was first introduced, and I found that people are really willing to give that. Next slide. So when the agency started developing the training and they were looking around, they felt like they wanted to really customize it to our agency. And so what they did was they put out an RFP, and they got back a response from a training developer known to our area. Now, you don't have to go this route. There are definitely vendors out there who can provide next generation training for call takers, managers, even staff on the state level that are running next generation programs. But this is what they wanted to, this is the direction that the leadership at the time wanted to go with. So we met with the training developers, and we had to provide, in our instance, the subject matter expertise. So through our trainers, through people like Selena and our CIO and others, we were able to provide all of the Next Gen 911 fundamentals. We used a lot of resources from the National 911 program. Again, great resources. We were able to give them that documentation and say, here's some of the messaging. Here's you know, how this job is going to affect call takers. And so we used that, and we worked on a weekly basis with our vendor to design a program, and a program that though it's done and it has a slide deck, and it has an instructor's guide and a participant guide, and it has quizzes, and it lays everything out in a syllabus, is completely editable. So if Next Gen 911, or, you know, as Next Gen 911 changes, we as an organization can go in, we can add, if better graphics come out, or we want to talk about something, or after we deliver it a few times, we want to tweak the way we're doing it, we can go in there and do that. Because just like any sort of syllabus or training material, it's very fluid, and it was made that way. So what we ended up with was a 7-module Next Gen IT training program, and we have 5 modules for our call takers. Next slide. And our training metrics for our agency stay the same as type of training. We, you know, always are tracking if employees are passing, how much are they interacting. You know, this was something that we had learned, that we were offering a lot of training, but we weren't really ensuring that people really understood it. And as we would ask people, hey, did you get that? Did you understand it? They were saying yes, but then as we were looking at calls that they were taking and processing through our QA process, we were like, I don't think they're really understanding exactly what we were trying to tell them. And so one of the things that we really were focused on was taking you know, something that is very, very technical and making it digestible. And when you have 225 operations staff employees, and 400 total employees in a center, that's going to look a little bit different to everybody. So in the development of our courses, we you know, we have activities for all styles of adult learners. And so I think that was one thing that was really beneficial for us using a curriculum development organization. So we do give that post-training assessment. We measure, you know, to ensure that everybody knows what they're doing. We're using those results just as informational, not as punitive, you know, and then we're definitely going back and following up with people as applications advance, as you know, we add widgets, you know, such as Smart 911 or Rapid SOS, where callers can go in and put on their profile. Do you understand what this means? Do you understand what you're seeing? You know, we're encouraging them to look at the application from the user side of things as well, so that they understand what the caller has input, or what the caller you know, things that you might have when they're calling you. Next slide. And like with anything, you know, we did come up against some challenges and barriers, but I think, you know, the key is really to just, you know, working through that, seeing what other places are doing, and that's really why we wanted to share our experience today, because it does kind of maybe sometimes seem a little overwhelming, and this was no different. You know, we had that difficulty of sourcing of vendors, and that was just you know, maybe not knowing exactly what it was that we were looking for. We had the issue with technology after a system upgrade. That's always something, you know, why Selena's not here today, because the best laid plans, especially when it comes to technology upgrades and integrations, can sometimes get foiled by one thing or another. We had, of course, the pandemic. Everyone except for our operations staff was out of our building from March, and we just returned to full capacity here in July. We have to also think about the scheduling. We work 12-hour shifts. We can only offer training on certain days while keeping with our minimum staffing guidelines, and so we had to work around that. And then we also have to think about the fiscal things, right? The bean counter is always there going, you're spending way too much money. And that's why, we have to go, that's okay. This is for the greater good of everybody. And then, of course, staffing challenges. And again, some of that being related back to the pandemic. Somebody gets sick, they're out for 2 weeks. And of course, the same thing happening with instructors and things like that. So we definitely experienced some challenges. I think we definitely ourselves have learned some lessons, and hopefully those are things that in this brief presentation we were able to share. And I know that Selena and I are always willing to share our very transparently our experience with things as we migrate. So I would just ask at this time if anybody has any questions. We'd be happy to answer them. If they're too techy, I'll punt them to Selena, and she'll have to get back to you.
Thank you, Heather. I think that's perfect. So with that, we're going to go ahead and start the Q&A portion of our session. And as a reminder, you can ask a question by using the question feature on the right-hand side of your screen, or you can always raise your hand and we will unmute your phone line. With that, Sheila, do you want to ask our first question?
Yes, thank you, Sherry. Heather, what has been the feedback on this training from call takers and dispatchers?
So for our call takers and dispatchers, so far, so good. I think people are really glad to get the opportunity to understand something. I think one of the things that we're hearing from IT is that they're really excited to not just have to figure something out. And our supervisors for our call takers and dispatchers have said the same. A lot of times they're coming to us and they have an issue, or they're not able to navigate something, and we're not really sure how to help them. So I think on all levels, this has been really well received. We also have a labor union here, and it's been well received by them as well, that they feel prepared going into this migration. So I would say overall really well.
Thanks, Heather. Looking to the vendor side of things and recognizing NG911 is a very new and niche subject, how did you go about finding vendors to provide the training, and what would you say was the quality of the training for the vendors you were able to source and find?
So in full transparency, when this project started, I did not work at OUC. I was doing something else in the industry. So when I came on board, we had engaged a vendor who had no 911 experience. They were a curriculum developer. And so we, as the executive staff here at OUC, we're giving them all of the materials. And so we were reaching out to our other vendors, our telephony vendors, our next gen vendors, the National 911 program, to really take what they had and to put it into a curriculum that wasn't, that was going to get the job done, being designed by people who really were also being educated at the same time. And I think that looking back, I think that would probably be my takeaway, is that we were really fortunate here that we had people who really understood the technology and other pieces of it, and our vendors really helped us get on board with getting that done. But there are vendors out there in the agency, there are firms that could do this without having to put a big burden on the operational staff or the leadership staff of the agency. And so while I think both ways are, are doable, if you're crunched for time, there are definitely places out there that could help you lead that charge without you having to sit on a meeting. Selena and I would sit on meetings weekly, sometimes 2 hours, saying, actually, this is how this works, and let me walk you through this diagram. And while I think that was great, I also recognize that not everybody has that kind of time. So that's kind of what I would say about that.
And the last question we have for today, Heather, has your vendor been able to provide you with statistics to help justify the expense?
So we're managing that. So if the question is, do we have people understanding it and moving on, then I would say yes, we're justifying the expense. I think the return on our investment has been great. If that question meant something else, I would probably just need a little bit of clarification.
And that's okay. Thanks, Heather. As we did earlier, if there are other questions that come in, we will capture those questions and get them to you for you to provide a response for. So I want to thank you and both of our other speakers earlier today. This is going to conclude today's webinar. And if we go to the last slide, we appreciate everyone's participation. As a reminder, an archived version of today's webinar will be available on 911.gov soon. And the next webinar for this year is scheduled on Tuesday. This will be November the 9th and at noon Eastern Time. And we hope that you will all be able to join us. Thank you again for joining us today and have a great rest of your Tuesday.